I think time will ultimately tell. So very much we have to be cognizant of exactly the point that you made, that a lot of kind of less specific tyrosine kinase inhibitors have not been effective in treatment of patients with microsatellite-stable metastatic colorectal cancer. I think that the BRAF mutated subpopulation of patients with microsatellite-stable colorectal cancer are perhaps more immunologically activated, have more immunologically active tumors than their BRAF microsatellite-stable CRC counterparts. Specifically, these tumors are often characterized by higher tumor mutation burden, which may generate more neoepitopes and neoantigens, which are recognizable by the immune system. But also they're characterized by higher rates of consensus molecular subtype 1, an RNA-based transcriptomic signature that is known to have higher immune activation at baseline too. So there are I think we have to caution in terms of thinking about immunotherapy combinations of lumping the BRAF mutated the fraction of patients into the larger MSS CRC population as a whole. On top of that, there's some very interesting data that was some preclinical work that had come out of Italy several years ago, where they looked in vitro at an MSS BRAF mutated CRC cell line, and they treated these with BRAF-EGFR inhibitors in cell culture, and found that when they did that, this generated a decreased expression of the 4 MMR genes and essentially induced an MSI high phenotype. So if what was seen, in the cell line model were to translate into humans, you would expect that treatments like encorafenib and cetuximab may effectively prime these tumors for response to immunotherapy. And we certainly are going to be looking at that in the correlative studies and translational analysis of paired specimens from our participants on our MD Anderson study. So I think your point is very well taken, but I think these are more specific tyrosine kinase inhibitors in a carefully selected population.